I'm Dr. Allan Perel, and this is Conversations in Medicine. This is Conversations in Medicine. I'm Dr. Allan Perel, your host. Tonight we're going to be speaking about different topics of medicine, things that are cutting edge to both the Staten Island and New York State community. It's my pleasure to introduce my guests, Dr. Milica Korocheva, Dr. John Pepe, both experts in the field of nephrology, internal medicine doctors who treat specifically kidney problems and high blood pressure. Hypertension or high blood pressure occurs in about 1/3 of the population. Over 75 million Americans have it. And interestingly, there's a lot of details about this. People in the Southeast have a higher prevalence than people in different parts of the country. There's a lot of details with regard to what's going on with hypertension. So we're going to get started, and I'll start with you, John. Tell us, what is blood pressure?
Well, blood pressure is the pressure created when the heart pumps blood into a blood vessel, and the resistance of that blood pressure, that blood vessel, how tight it is, will determine how high the blood pressure is.
So tell me, what is high blood pressure or hypertension?
Well, high blood pressure is defined nowadays as a daytime blood pressure of over 130/80. Prior to this, a few years back, we accepted numbers up to 140/90. But because various studies have shown improved survival and decreased risk factors for heart attack and stroke, the numbers have been revised down.
Melissa, how often should people have their blood pressure checked? How do you know if you have high blood pressure?
Well, there's no way to know unless you want to see your doctor, which is usually once a year for normal, healthy adults. And they determine if your blood pressure is 120/80, you're good, and you can go for your next annual exam. However, if your blood pressure is between 120 for the top number and 129, and if you do have risk factors, you should check it at least twice a year. Talking about risk factors, this is, as we may know, age over 60, or even lower for men, race, overweight.
So tell me about
overweight.
race. Do African American patients have a higher risk?
Absolutely, they have higher risk. Also the Latinos, the Pacific Islanders, they're already in this risk category. That means if the blood pressure is slightly elevated without being called hypertension yet, therefore it doesn't cross the 130 range, it should be checked twice a year.
And what do we call that? Is there a term between high blood pressure and normal?
It's called high blood pressure, but not hypertension. And when it is 130/80 and above, it's already hypertension.
So let's talk about, we have some things out here. It's always nice to see all these models. So we have a blood pressure kit. So John, if you go to someone's office, if I go to your office, could you tell if I have high blood pressure without taking my blood pressure?
Well, the definition of high blood pressure on a single value is 180/120. A second definition is 160/100 if there's target organ damage.
Which means what?
Enlarged heart, heart disease, arteriosclerosis, peripheral vascular disease, a history of stroke or
Right.
TIA.
As a neurologist, I see that very often. People will come in with small strokes and will notice that they have very elevated high blood pressure. And we'll also see that in the hospital when someone has a stroke. So let me go back, though. Everyone is concerned about high blood pressure. And everyone who comes into your office is anxious. They come into my office, they're very anxious. Does the anxiety of coming into your office, the white coat syndrome, they say, well, my pressure, I'm always fine. Just when I see you, my pressure is high. What do you recommend for someone like that?
Well, office blood pressures are almost always higher than home blood pressures. If I see a patient who has a blood pressure of 140/90 or 150/100 even, I'm not going to treat them immediately. I'm going to ask them to have that blood pressure taken at home. These cuffs are quite accurate as long as they're upper arm cuffs. They're more accurate than wrist and finger.
So show us the cuff. Show us a little bit about how.
So they sell these in all pharmacies. And it's an automated blood pressure cuff, and you just line up the arrow over your artery here. It's pretty self-explanatory. Push the button, it blows it up, and then it deflates the cuff, and it'll record the blood pressure and keep it in memory. As you do it repeatedly at home, the blood pressure actually tends to drop and drop and drop. In fact, people are now using ambulatory automatic blood pressure monitors in offices. A machine like this, they leave the room with the patient alone, and it repeatedly takes your pressure. And over a period of 5 and 10 and 15 minutes, the blood pressure tends to drop and drop. So basically, the true blood pressure is what the patient manages at home. Or if you have a 24-hour ambulatory blood pressure monitor, a cuff that stays on for 24 hours and records the blood pressure frequently, a daytime blood pressure there of less than 130/90 is normal blood pressure.
Let's go back to some of the definitions. John was talking about numbers, 180, 120. Let's go over there's two numbers we have when someone has a blood pressure. It's the top number and the bottom number.
Correct.
One could be high, the other one could be high, both could be high. Give me a little story about that.
Okay, so what creates the top number? So this is the pressure that's created when the heart beats and expels the blood through the vessels. That's the top number, the systolic blood pressure. The diastolic is, or the lower number, when the heart rests between two heartbeats. So some people have only the top number elevated, which is called the systolic hypertension. Some other people have normal systolic, but they have rather diastolic when the bottom number is elevated, 90 and above. In both situations, we're talking about hypertension, different types, and most commonly people have both the systolic and the diastolic elevated. So the interesting part is that even if it's only the lower part, let's say it's 90 and above, it does count as a good elevated blood pressure. And of course it has to be taken on 2 different occasions. Patient has to be rested well, not coming out of the door and sitting and taking the blood pressure. Even if it's repeatedly elevated, that gives you the diagnosis of diastolic blood pressure. If we have made already the diagnosis, we need to screen for end organ damage, as John mentioned. Why? Because the importance is so big and the cardiovascular complications are so much. If we do find that, let's say, a patient has left ventricular hypertrophy, or they have already...
Which means what, an enlarged heart?
An enlarged heart because of the increased workload of the heart. The heart muscle undergoes changes. It becomes thicker, less relaxed, and it pumps and works hard to push the blood out through the vessels. So by doing this, there's obviously more risk down the line from cardiac standpoint. People may have cardiac arrhythmias when the heart muscle becomes bigger, or they may have a heart attack, or at the end, heart failure. Actually, there's an interesting study, I think it was a year or 2, published, more than 1,000 patients, primary hypertension, never had any blood cardiovascular events. They found in those people with hypertension that 30% of them already had left ventricular hypertrophy. And why people pick these numbers, 130/80? It's not like a random number. They do just because they associate what is the relationship between the blood pressure and the cardiovascular morbidity.
What I think is so interesting, if you go to your eye doctor, ophthalmologist, and they look at the back of your eyes when they dilate your pupils, you could see changes of high blood pressure even in the back of the eyes. So it doesn't have to be organs that you that you would die from, but those are symptoms that are happening. So tell me, do most patients with high blood pressure know they have high blood pressure? John?
Most patients don't know they have blood pressure. The vast majority don't.
Especially early on.
By the time blood pressure causes symptoms, it has to be generally over 160, greater than 160/110. Sometimes that'll cause a headache. 180/120, not only a headache, but confusion, occasionally seizures, strokes, swelling in the back of the eye, increased pressure in the brain, so-called papilledema, kidney failure. So, but that's the exception. Most patients don't know they have high blood pressure, and that's why they have to be screened.
So let's say Melissa was talking about going to your doctor annually, and many people do, some people don't. Say someone had their blood pressure taken at a pharmacist or an urgent center, if they just weren't feeling well, there was a nurse there and a friend took a blood pressure and it was high. She mentioned a term called primary hypertension, secondary hypertension. Tell us a little bit, how do you work up when someone comes into your office? Or, and maybe I'll even go a step further, who takes care of high blood pressure?
Most general practitioners, internists will do that.
When do people have to go on to a nephrologist or someone who specializes in this?
With resistant hypertension, usually.
Doesn't
That means
respond?
if they don't respond to 3 drugs or more in general, they should see either a cardiologist or a nephrologist.
So Melissa, tell us, you mentioned primary hypertension. Maybe just for our audience, describe to them what that means.
So this is the most common form. It probably accounts for about 95% of all the hypertensions. This is the one that we see most commonly. It's called also essential hypertension. In this type of hypertension, family history is big. Usually one of the 2 parents have elevated blood pressure. Age is important risk factor for this. Overweight, smoking, excessive alcohol consumption being also a big factor in this. In other words, if we cannot find another reason for patient to have a blood pressure in terms of maybe renovascular or endocrine hypertension, as we call it, when do we suspect it? Well, normally when somebody comes to the office, newly diagnosed hypertension, we do, aside from checking the blood pressure on both arms and examining the vascular arteries everywhere in the bodies in order to make sure they're symmetric, there's no major abnormality, we do basic workup, we call it. Blood work to check the kidney function, the urine test to screen for proteinuria, albuminuria.
For an abnormal kidney.
Right, and thyroid function tests, these being the most common causes for the general population if you don't have overactive thyroid or you don't have albumin. So these are the tests that point out for possible secondary hypertension.
So primary hypertension just happens. It's a genetic predisposition plus
Exactly.
some of the bad things we do.
Right.
And the one thing we've gone almost halfway into the show and no one's mentioned the word salt yet.
Correct.
So tell us about salt.
How salt is important, extremely important. How much salt do we normally eat? In the American diet, probably what, 5-6 grams a day?
A lot.
A lot, okay? And why is it important, salt? What does the salt do to your body? You drink water, right? So if you drink water, you'll be, that means you're going to retain this water. So the kidney, if you have normal kidney, is going to work hard to excrete this water. However, some people have problems with excreting the water for different reasons. They might be having either some degree of renal insufficiency, or they may be having some heart failure, or they may be having some tubular disorders in the kidneys that prevent this from happening. So this is basically, I'm glad you brought it up, the basic pathophysiology mechanism for blood pressure. You have high fluid level plus high resistance in the vessels, that's created the blood pressure. That basically makes the first treatment choice. You have to reduce the fluid.
So John was talking to me earlier about volume.
Right.
And whether it's a volume of water in a cup or a volume in your body, everything has to be in equilibrium. And that's sort of the homeostasis or the equilibrium of the body. So tell us a little bit about volume control with regard to hypertension. If somebody comes into your office, and I know that you're a subspecialist with hypertension, but just comes in for another reason, family member, and the pressure is high, and they say to you, I really don't want to go on a medicine. Do you allow them to try to go on a diet, low salt diet? You know, what recommendations would you have, and how do you think about that?
Unless there's a compelling reason to give them medication, which is a blood pressure of over 160, over 100. The initial approach would be non-pharmacologic.
Non-medicine.
No medication. It's a low salt diet, exercise, decrease alcohol intake, avoid anti-inflammatory drugs like Aleve, Advil, ibuprofen, nasal decongestants, steroids do it, prednisone. various weight loss medications, stimulants. All of those things can do that. And then we may or may not screen, as Dr. Karachev said, we may or may not screen for secondary causes of high blood pressure, thyroid disease. The adrenal gland sometimes produces a hormone in excess that can cause high blood pressure. Licorice in high doses can cause high blood pressure. So, you know, we have to look at all of those possibilities when we see a patient, but generally 90+% of the time, these patients have what's called essential or idiopathic hypertension. They have an intrinsic inability of their blood vessels and their body to adjust the resistance of the vessels to the pressure that to create normal pressure.
So you brought some wonderful models here tonight. And we're going to talk about treatments now. And I want you to help me, as someone who works in the hospital, as a neurologist. Neurologists aren't too heavily into kidneys and volume. We're into our brains and things like that. But you know, sometimes the body has to get enough oxygen and blood to the brain for it to work. So we are interested in the kidneys too. Telling us a little bit about this, let's go over some of the medicines. We have a very sophisticated audience. People know that there are a ton of different medicines, and people are on different medications. And maybe you can give us a little idea about what these medicines are. What are the starting medicines, maybe some stronger medicines? And we have three models here. We have a wonderful model of the kidney, one of the heart, and another kidney, because we do have two kidneys and we have one heart, as you told me, Melissa. So tell me a little bit. Tell us about medicines that we use. Maybe we could start,
Yes.
so if we're going to start someone on something.
So you basically brought it up. The first goal when we're treating blood pressure is to reduce the salt content in the body. It happens when you reduce the dietary salt in your food, up to no more than 2 grams a day. And also very important to mention the so-called DASH diet, standing for dietary approach to stop hypertension, which is basically not only reduced salt, but also reduced meat, and using mostly plant proteins and nuts, but you're reducing a lot of the animal protein that's heavily in the American diet. We know that with diet alone, we can probably drop the blood pressure by 4 to 5 millimeters.
So the numbers from 140 to say 135, something
Exactly.
like that.
So we tell, okay, you should exercise. Even if you don't lose weight, exercise alone can drop the blood pressure, but no more than, again, about 4 millimeters. Mm-hmm. So when people say, okay, we don't want medicine, my blood pressure is 160, I just want to use this natural ways of losing weight. We know it may work down the line, but it's going to take time, number one. And number two, if the blood pressure is 20 millimeters above the goal, you know that you'll need medicine already.
So if someone is, we'll give them real numbers. Dr.
150.
Pepe said 130 is the cutoff. If you're over 150, you're
50,
probably.
you
So
probably
what's
have
the
to-
first medicine? People always, I remember my grandmother having high blood pressure. It was always a water pill. And that's what it
Correct.
was. So tell us a little bit about different medicines. I want to jump into the medicines a little bit, because people are on these medicines, and people are afraid of the side effects and what they are and how they work.
Various people by race, gender, and age will respond to different medications better, different classes of medications better than others. So the three most common medications, classes of medications, are diuretics, which are water pills, thiazide.
And what do they do?
And they decrease the volume in your body.
Show us the kidney. What are they actually doing?
They act on the tubules in the kidney to block salt reabsorption. So as salt is filtering through the kidney, it normally gets reabsorbed back into the blood, so that the volume in the blood stays where it is, because that body does not know how to adjust it properly. So we give them a pill, and it blocks the reabsorption of sodium so that the patient makes more urine, excretes the salt and water, and that in certain patients will be a first-line drug to decrease blood pressure. Now, there are other classes of drugs. The second class of drugs are called calcium channel blockers. They work on blood vessels to dilate them.
Show us on the heart a little bit. What would happen? Actually, Melissa,
well-
you could show us on this one. You're closer. So what would it do? So it
They're going to relax the heart, because the calcium channel blockers, there are a lot of subtypes. Since the heart undergoes changes like hypertrophy, they're going to relax the heart. Therefore, it's going to make less force pumping out of the heart, Therefore, it's going to relax not just the heart, but also the vessels. In this way, when it's high, the more dilated the vessel, the blood pressure is going to drop.
So show us, everyone's looking at the model now. So
This is the heart, this
Right.
is the pumping unit, and this is the vessel, the major vessel that comes throughout the body. You can imagine that every time the heart pumps out, the blood pressure jumps, that creates the top number, and then when it goes down the vessel, the vessels, and they are very stiff, over time they become very stiff and resistant, it's going to create high pressure. With those medications, they're going to relax and respond to treatment, therefore it's going to basically reduce
So
the blood
it relaxes
pressure.
the blood vessel, reduces resistance, lets the blood go through a little bit easier, and it
Right.
makes the heart not as pump
It's
as hard.
stiff and correct.
So let's go over, so we talked about calcium channel blockers. Could you give us an example? I mean, everyone I see is on something called Norvasc or amlodipine.
Correct.
Is that one of the more common medicines you have?
Yes,
at least
that and Procardia and nifedipine, they're all of the same class.
So I want people to hear, because they might be on these medicines. The diuretics you mentioned
Right.
before. There's a drug called hydrochlorothiazide. Maybe you can give us some other examples.
Hydrochlorothiazide, amiloride, spironolactone.
Right, all different ones.
Hydrotalidone.
Now, in my practice, for some reason, I just see so many patients on a medicine called metoprolol. And people, for a number of reasons with high blood pressure, maybe you could tell us how that works, because people are always interested in how their medicines work and whether it's a good medicine for them.
Metoprolol is called a beta blocker, and it blocks the blood vessel receptors.
Show us, and we have models.
On blood vessels, there are receptors, and these receptors react to various hormones, and beta blockers will block the constriction of this vessel, so that the vessel does not constrict as much, and it tends to relax, and the blood pressure tends to fall. At the same time, it has a direct action on the beta receptors of the heart, and it slows the heart down. So these drugs tend to slow down the heart rate and lower the blood pressure.
So since these medicines work differently, that's why some patients are on more than one medicine? If they
Yes.
have a problem with, you use the word resistant hypertension.
Right.
If everybody took one pill and they were fine, everybody would be happy, but things don't happen that way.
For example, African Americans tend to respond better to calcium channel blocker drugs like amlodipine and nifedipine. Younger patients tend to respond better to what's called ACE inhibitors, which block another hormone that constricts vessels. Older patients tend to respond better to thiazide diuretics. So you pick that population where those patients would be best served.
And you talked about the side effects of people who have chronic high blood pressure. I always think of the idea of plumbing. And if you have too much pressure coming through your pipes, one of two things happen. It either clogs off, and that's where you get a stroke, a heart attack, or it pops, and you get
Right.
bleeding. So aneurysmal bleeds, bleeding in the brain called cerebral hemorrhages. So that's the way I sort of think about the plumbing and the pressure that we have. What if somebody is, give us some idea. We talked about some of the medicines you said, ACE inhibitors, beta blockers. What are the new things going on in hypertension?
I think that nowadays we are more aware that there's certain medications that are very beneficial, not just to lower the blood pressure, but they really change the structure of the heart in a way to make it more relaxed. And not only that, but it does show that, for example, angiotensin receptor blockers and inhibitors may cause regression of the left ventricular hypertrophy.
So it might actually help. And give
Yes.
us some names of some medicines.
For example, this is enalapril, valsartan,
Losartan, I'm sure.
losartan is the same, more often used now. There's also calcium channel blockers do the same thing with the LVH. The regression of LVH is not seen with hydralazine, with minoxidil, with your.
So
these
some
are
of these
like
medicines actually
second
help.
line, correct.
Because I don't want to go too
So,
fancy into names.
Exactly.
So tell us, John, a little bit, again, a little bit about new things. Someone who has intractable hypertension, maybe I'll even ask a different question. Could you control anyone's blood pressure? As a nephrologist, say your internist is having a problem controlling medicine with multiple medicines. Do you have at your availability the possibility of controlling almost everyone?
Almost everyone. But there are patients who are not, who don't respond. A lot of people have come up with a couple of techniques. There's one that denervates the carotid sinus, which is the sensor for blood pressure. And another one, another
It's a surgical procedure then.
It's a surgical procedure. Another one denervates the arteries going into the kidney. And although they reported initial success in large-scale trials, these are not uniformly successful.
If we can just add, actually I happened to speak to one of the authors. There's 2 new studies going on now. After the first, the Simplicity trial 2 and 3 that proven that this is not a viable option, the renal denervation of the kidney. There's 2 ongoing trials and they're recruiting patients. I had to speak to one of the investigators because one of my patients just doesn't want to take medications. Her blood pressure is quite high. So there's special category whether either patient don't tolerate the medicines or they just don't want to take them. In this situation, probably it's not a bad idea to refer them to those centers. However, since the design of the study is created such as they don't take people with chronic kidney disease, I was out of the equation, couldn't offer. They have a lot of limitations. But it seemed to be promising, and the new day, I think, improved the techniques of the radio frequency ablations, sono-guided techniques.
So you're talking above everyone, and at this point, these are all kinds of different techniques.
Experimentals, right?
I hear you. So tell us, your patients, talk about compliance. I mean, you're going to look out there and talk to our wonderful audience, and you're going to look at your patients. I mean, so many people know you both on the island and throughout New York City. How important is it that they not miss medicine, that they take their medicine as prescribed?
It's critical.
Tell everyone, John.
It's absolutely critical. Non-compliance is probably the most common reason that patients' blood pressure is not controlled.
But people sometimes are not compliant because of side effects. And I've seen medicine change over the 25 years I've been in practice to the point where we have so many different medicines in most fields. We're able to find a treatment that will get us the end result, in this case reducing blood pressure, and keep the side effects reasonable. I mean, there are side effects with all these medicines. As you said, these medicines work on the heart, they work on the kidneys. Some of these medicines have issues like, and we didn't even mention this, maybe you can mention it briefly. What happens if you're too aggressive with blood pressure control? What do people say if their pressure goes low? They use the word hypotension.
Right. That's a common side effect in certain people, especially if they have other diseases like diabetes, neuropathy. It happens more often. So we are aware. If, and this is, the indication where we really advise people to have home blood pressure monitor to know what's the highest, the lowest, or ambulatory. And we have to have certain goals. We shouldn't be probably hitting the 130, 120, 80, but a little higher. And trying to investigate why people are having the low blood pressure.
So we can't go too low. And I'm going to interrupt you because we're at the end of the show. I want to thank you both for being here today. As I said to both of you, this will be the quickest half hour that you'll ever know. And it's just so important for our audience and for everyone to take your medicine properly. We've had 2 wonderful experts. You are able to, in most cases, control people's blood pressure. If blood pressure is not controlled, you might feel fine. But then a devastating thing such as a heart attack, stroke, kidney disease could happen. So please, thank you, and stay on your medicine. It's a third of us, and it's important to be on your medication.
Thank you, Allan.
Thank you.
Thank you.
Thank you for having me.